Hello, my name is Julia Birnbaum, and I am a breast radiologist at the University of Pennsylvania, where I have practiced for the past 27 years. I did a fellowship in women's imaging and initially practiced in ultrasound as well as breast radiology, but for the past 9 years have limited my practice solely to breast radiology. My responsibilities include teaching residents and fellows, as well as taking care of patients. One of my special interests is percutaneous biopsies of the breast and other procedures that we do in breast radiology. And I think that specifically mammographic-guided core biopsies, although they are initially intimidating, are actually fairly easy to perform, and all radiologists who perform breast procedures should be comfortable with this type of procedure. For today's talk, we're going to cover general considerations for core biopsies of the breast, and then specifically what are the indications for biopsies with mammographic guidance. We'll spend some time talking about the two different techniques that can be utilized during mammographic-guided core biopsies, and I will mention contrast-enhanced mammography. We will review challenges specific to the technique we are using, and as well as specific patient challenges and some modifications that we can use to overcome these challenges. Towards the end, we will do one procedure from beginning to end, and then I will follow with some comments regarding radiology pathology concordance. The goals for today are to have an understanding of mammographic-guided core biopsies in general, understand the difference between targeting using stereotaxis and tomosynthesis, to know the typical targets for mammographic-guided core biopsies. You should be able to troubleshoot challenging cases, understand the importance of advanced preparation, and understand the basics of radiology pathology correlation, specifically for mammographic-guided core biopsies. So why do we do percutaneous biopsies versus surgical biopsies? It will definitely decrease the time to diagnosis. Many times we can do the biopsies same day or next day, versus a surgical biopsy requires a consultation with a surgeon, pre-op testing, and then getting on the OR schedule. In general, percutaneous biopsies should decrease the total number of surgical procedures for a patient, whether or not the diagnosis is benign or malignant. For example, if the diagnosis is benign, the patient may never need surgery, so the number of surgical procedures has gone from 1 to 0. If the diagnosis is malignancy, then the surgery can be tailored specifically for the best procedure for that patient. So the excisional biopsies are a very different procedure than lumpectomy. So if diagnosis is known beforehand, then the surgeon can tailor the exact correct surgical procedure for that patient. Knowing the diagnosis in advance allows the patient and the surgeon to have discussions regarding the different options and the patient preference if there are different equivalent options for the patient to choose between. And some patients are actually diagnosed with distant disease at the time of diagnosis, and the core biopsy of the breast may be utilized to identify the source of the cancer, and that patient may never need surgery. So we've gone from any surgeries to 0. So again, decreasing the total number of surgical procedures, which are more invasive and do require anesthesia. Core biopsies provide useful information whether or not the diagnosis is benign or malignant. If it is malignant, we can get receptors, and that has therapeutic and prognostic information up front. Some patients may actually get neoadjuvant chemotherapy before they get surgery. The core biopsy may show us whether or not the cancer is invasive or in situ. And in terms of benign findings, the core biopsy may show a high-risk finding, which would imply the patient needs imaging follow-up, risk reduction medication, and/or supplemental imaging. And then some patients with benign diagnoses still need surgery. Why would we specifically use mammographic guidance rather than ultrasound or MRI guidance. Well, there are findings that are solely seen on mammography. Typically, these are calcifications. However, there are some masses, asymmetries, and distortions that are sonographically occult. And so we default to using mammography for guidance of the percutaneous biopsy. There are some advantages for using mammographic guidance. Does not require contrast. It uses available technology. In fact, there are some mammographic guided machines that are add-on to a typical mammogram unit and don't require a special room. Also, we have the advantage of specimen radiography for targets of calcifications, which can confirm satisfactory sampling. Some of the disadvantages of using mammography for guidance include discomfort for the patient. I'll be showing you pictures of what the biopsy tables look like, and they're pretty uncomfortable. Does require radiation. Lesions near the chest wall or in a smaller, thin breast may not be amenable to biopsy under mammographic guidance. We also don't have the real-time visualization of needle in the target, which you would have with ultrasound guidance. And also, if the target is non-calcified, there's no way to confirm with a specimen radiograph that you've been successful. Overall, mammographic-guided core biopsies are less preferable than using ultrasound, but more preferable than utilizing MRI. A brief word about the needles used in mammographic-guided core biopsies. We use vacuum-assisted needles currently. Decades ago, we used spring-loaded needles. Right now, I think that most facilities would have vacuum-assisted needles. Regardless of the manufacturer, the parts of the needle are very similar. They all have a tissue acquisition chamber that the vacuum pulls the tissue into. This can be called the trough, the notch, or the aperture. There are options for length of that aperture, which I'll go over a little bit later, as well as gauge of the needle or diameter of the needle. In short axis, you can see that the trough or the aperture is directional. It's not entirely over the circumference of the needle. It's facing one direction. So for example, this yellow circle is the target, the trough is the straight line, and the white is the needle. And then the needle can be rotated 360 degrees to obtain different sites of sampling within that target. In some cases, the needle is at the periphery of the target, in which case we may only sample in a few different locations. For example, this arc of a circle. Moving on to discussion of technique of mammographic-guided core biopsies. This is a 53-year-old patient who had a screening mammogram performed, and there are new calcifications in her left breast. I'm circling them here because they are very faint and hard to appreciate without the ability to zoom in on a mammo workstation. These were called BI-RAD 0 and need additional imaging evaluation. Remember that the only BI-RADs available for screening is 0, 1, or 2. The patient was called back for diagnostic evaluation, and magnification views were performed showing grouped amorphous calcifications, which are new, harder to see in this view. And because of these features, they are BI-RADS 4B suspicious. These are not the type of finding that we would interrogate with ultrasound. It would not be helpful. We would not be able to see these small particles. There's no associated mass. So we would proceed with biopsy using mammography. So how do we get the biopsy needle to the target? So each point in space, each target can be defined by 3 coordinates of X, Y, and Z. So the goal of mammographic targeting is getting the needle to the biopsy site. X and Y are very easy to determine from a single 2D image. X is parallel to the floor, Y is perpendicular to the floor. The challenge is determining the depth, or Z, of the target. Again, a diagram of a patient being positioned on a prone stereotactic core biopsy table. Here is the detector. Here's the paddle that is compressing the breast. It actually has a window which allows the needle to get into the breast. and the X-ray tube would be beyond the field of view of these pictures, but would be on the left. Here's a slightly magnified view of the same things: detector, compression paddle, here's the needle, and this is the target. So the depth, or Z, is the distance from a reference point. And the reference point can vary depending upon the manufacturer, from the surface of the breast or from the detector. So Z, the point of reference, varies depending upon the manufacturer. So there are two different techniques for finding that Z for a biopsy. The two different techniques are stereotactic imaging and tomosynthesis. So we're going to start discussing stereotactic imaging, where Z is determined by the target's apparent change in position relative to a reference point when seen on angled views. That's a mouthful. That is what parallax shift is. To start with, two images are acquired with the X-ray tube in different positions. So here's the scout view at 0 degrees. And here's a target of grouped microcalcifications. We get a view at positive 15 degrees and a view at negative 15 degrees. The target of the lesion appears to change position in the X dimension between the two projections. You can see it looks more towards the left here and more towards the right here. Z, or depth in the breast, is determined by the target's apparent change in position relative to a reference point. You don't have to know this calculation, but there is an actual mathematical formula that the computer does, and it shows the change in X divided by 2 tangent of 15 degrees gives the change in Z, meaning the difference in Z between the target and the reference. Going back to our patient with new grouped calcifications, we would obtain an image at positive 15, an image at negative 15. There's positive, there's negative. At the workstation, we place our cursor on the target, manually selecting X and Y by placing the cursor on those targets, and then the computer will do the calculation and provide Z, or depth. On the workstation, this is what it looks like. We're going to see, after we choose our target, X, Y, and Z here, and we click check here, and it magically transfers the coordinates over to the stage of the needle. This is what's right below the needle next to the patient. And here we can see the target, the X, the Y, and the Z. And when you're doing the biopsy, the needle should be at the same coordinates, X, Y, and Z. And so you know you're at the appropriate position because the difference between what the target is and where your needle is 0. We take pre-fire images, and on these images, the needle should point directly at the target on both views. There is a button to press where the needle fires or advances. The throw on many of the needles is approximately 2 centimeters. On those post-biopsy images, the trough should align with the target on both views. In this case, the target calcifications align with the trough, although they are towards the nipple. This would be chest wall in the patient, and then this would be the nipple down towards the bottom of the screen. And so we would orient our trough towards the nipple and sample in that direction. We would obtain a specimen radiograph. Here are the specimens arrayed in a core biopsy specimen container. And this is the radiograph of those same samples. The reason we do specifically in this core container is that our pathologists like to have our specimens separated between those that have calcifications and those that do not. They do look at everything, but they like to do their own RAD-path correlation and make sure they know that they are looking at the target calcifications. Over here in the top left is just what these specimens look like in the container that's attached to the needle. There are errors that can happen during targeting for stereotactic core biopsies. On pre-fire imaging, I mentioned that the needle should point directly at the target on both views. In this particular situation, the needle is to the right of the target on both views. If this is symmetric to the right or the left of the target, the error is in the x-axis or horizontal to the floor. So we just need to manually move the needle to the left along the x-axis to align the tip of the needle with the target. This is a schematic of a post-fire image. Remember that on the post-fire image, the target should be aligned with the trough. In this case, on the post-fire image, the calcifications are aligned with the trough, but they're too far away. So this is an error in the y-axis. And all we need to do is move the needle superiorly or towards the patient's chest wall on a prone stereotactic table in order to be at the appropriate site. Here's an example of a post-fire image where the needle is still pointing at the calcifications. Recall that I mentioned that on the post-fire images, the calcifications or the target should align with the trough on both views. In this case, if the trough is symmetrically proximal or distal to the target on both views, the error is then in the x-axis. So here, we would just need to advance the needle to bring the trough adjacent to the calcifications on both views. There are times where errors are compounded. Again, as a reminder, on post-fire images, the calcifications should align with the trough on the post-fire images. In this example, one image looks correct, but the other doesn't. That means that there must be two errors, and it's usually X and Z that are compounded. If we move the needle to the left along the x-axis and also then advance the needle, we would bring the trough adjacent to the calcifications on both views. Moving along to targeting using tomosynthesis. This is how we identified Z by the number of 1 millimeter slices between the reference and the target. Here is our patient on a prone stereotactic table, and Z is the number of 1 millimeter slices between the reference and the target. Again, the reference can be at the paddle here at the surface of the breast where the opening is, or at the detector, depending upon the manufacturer. An example of a patient who had a new group of calcifications in the left breast, showing you this group of 3, not particularly suspicious morphologically, but definitely new, and therefore needed to be biopsied. We chose to target these from an inferior approach, so a CC from below, and we obtain a tomosynthesis series. This is a single slice of the tomosynthesis series showing that the calcifications came into focus at 35 millimeters from the detector, which is 1. This is the head. Remember, we're coming CC from below, so this is the head and the paddles at the feet. So we've determined Z just by the distance from the reference point. Another example of calcifications seen on a screening mammogram in a patient who has a history of reduction mammoplasty. Just photographic mags of these calcifications. These were recalled because they looked coarse heterogeneous and they were new, although it does look like there is some lucency associated with these calcifications, suggesting the possibility of fat necrosis. Diagnostic evaluation was performed with magnification views and an ML view. And the radiologist on that day wanted to pursue biopsy despite the fact that these had a likelihood of being benign fat necrosis. The calcifications are located at 12 o'clock at a middle depth. A superior approach was chosen for targeting. So again, the patient is placed in a CC projection with the first slice being at the foot and the last slice being at the surface of the breast towards her head. And here is the slice where the calcifications come into focus. So we're able to determine our Z depth basically on our first scout series. After lidocaine was placed, we did a repeat tomosynthesis series, and we like to do this because the calcifications can be displaced by the volume of local anesthetic. On a pre-fire image, the needle is pointing directly at the calcifications, and you can see the calcifications are in focus on this slice right where the needle tip is. And we opted not to get a post-fire image because with tomosynthesis, the needle can obscure the underlying target. Specimen radiograph shows calcifications in several cores. Here's some calcifications here and up here. And the diagnosis was fat necrosis. This was biopsied last week, but the results came back rather quickly. A clip was placed. Notice that these are stereotactic images obtained. The reason we do this at our institution is because we do not have a code for tomosynthesis biopsy. All of them are scheduled as stereotactic biopsies, but most of them are now done with tomosynthesis. Because we are charging for a stereotactic biopsy, we do need to obtain a stereotactic pair sometime during the biopsy. And most of the time we choose to do this at the end after clip placement. So here's the clip and residual calcifications. Post-biopsy mammogram should always be performed and compared to the diagnostic and screening images. So CC views on the left, here's the pre-biopsy, post-biopsy showing the clip adjacent to the calcifications, pre-biopsy ML view, post-biopsy ML view, again showing the clip adjacent to the calcifications on both views. A few words about the importance of the post-biopsy mammogram. In the situation we just looked at, there were residual calcifications. So if the clip were displaced, that wouldn't necessarily be a problem because we could still, if necessary, use the residual calcifications for targeting, for localization. If there were not a residual target and the clip were displaced, it may be challenging to localize the biopsy cavity, and this should be known in advance. Sometimes additional imaging needs to be performed to find the original biopsy site if it's cancer, such as an MRI. Also important to consider on the post-biopsy mammogram is whether or not you biopsy the right thing. Sometimes patients have multiple groups of calcifications, and on the biopsy table, it can be a little bit confusing. So it's always important to look at the placement of the clip following biopsy to confirm that the correct group has been biopsied. Targeting errors with tomosynthesis usually occur in the z-axis. Sometimes after sampling in a specimen radiograph that does not show any calcifications, we need to retarget because we probably were in the wrong spot. And I mentioned that the needle with tomosynthesis can obscure the underlying parenchyma. So you may need to withdraw the needle and re-image and then retarget if necessary. In addition to calcifications, there are other findings that may be targeted with mammographic biopsies. That includes asymmetries, masses, architectural distortion that may be sonographically occult. With these types of targets, lidocaine can often obscure the underlying target. So just keep that in mind. It's harder to see the underlying target for a non-calcified lesion compared to a calcified lesion. In addition, there's no specimen radiograph to confirm that the target has been sampled, as you would have with a target of calcifications. How do you choose whether or not to use tomosynthesis or stereotaxis? In general, I default to tomosynthesis almost 100% of the time. It is faster. We obtain fewer images. So not only is that faster, but the patient receives a lower dose of radiation. As I mentioned, the targets may be harder to see on post-fire imaging, and I also mentioned that currently there is no billing code. Currently, I use stereotaxis for problem solving. So if I am having trouble getting calcifications or seeing calcifications on tomosynthesis, I default to stereotactic imaging. I may have a better idea of where the calcifications are and where the needle is relative to the calcifications. Some facilities may actually not have the ability to perform targeting under tomosynthesis, so then they would perform under stereotaxis. So sometimes lesions are seen only on contrast imaging. At my facility, we do not do contrast enhanced mammography. So I used a resource to obtain some information to present here. Importantly, the breast would be positioned in compression before injection of contrast. You can target with stereotaxis or tomosynthesis with contrast enhanced biopsies. The initial post-biopsy imaging is usually obtained 2 to 2.5 minutes after injection. It's important to work quickly to optimize the detection of the lesion relative to background enhancement. Just like MR, there can be washout of a target and background parenchyma will progressively enhance over time. So you need to work early and quickly to see the lesion the best. Following identification of the target, the remainder of the steps is analogous to routine mammographic-guided core biopsies with tomosynthesis or stereotactic imaging. Like any biopsy performed, we worry about bleeding and infection. I tell patients that they should expect to have some bruising because everybody bleeds at least a little bit. Patients who are on blood thinners obviously would have larger amounts of bleeding and bruising. We do not cancel our procedures if patients are on anticoagulation. We just counsel them to know what to expect, and we hold pressure a little bit longer after the procedure. The likelihood of infection after a core biopsy is very low. These are not sterile procedures. However, we do clean the skin off, and everything we put inside the breast is sterile. As long as you know what you can and cannot touch, the likelihood of contaminating a patient is very low. And in my practice, I've known of maybe 1 or 2 infections that have come back to me. There may be others, but it is, I know, uncommon. There are additional problems with core biopsies, not necessarily complications, but things that require potential additional procedures or at least some type of problem solving. We'll talk a little bit more about discordant pathology that might require a repeat biopsy or surgery. This would not be known the day of the biopsy. It would be known in a few days when the results are available. There's also the problem of inaccurate clip placement, and this would be known the day of the biopsy with the post-biopsy mammogram. About 5% of cases show a clip more than 1 centimeter from the target. This mostly happens with mammographic-guided procedures due to the accordion effect. So what does that mean? So here's an accordion. Here, these are called the bellows of the accordion, and they are compressed in this image. And notice the space between these folds is very, very minimal. But when the accordion is expanded, these folds in the bellows are farther apart. So distance when compressed is very little, but may be magnified when the structure is expanded. The same thing happens with mammographic guided core biopsies and also with MR because the breast is compressed for both of those procedures. So if the clip is placed when the breast is compressed and maybe a few millimeters off, when the breast is taken out of compression, those few millimeters can be exaggerated. And sometimes the clip is even a few centimeters displaced from the target site. Other technical problems include breast that does not compress to a satisfactory amount, targets that are deep, closer to the chest wall, and then patients who have decreased mobility or who have back or neck problems. So let's talk about the thin breast. What are the technical requirements for performing a mammographic-guided core biopsy? Well, in the standard approach, where the needle is perpendicular to the plane of compression, all of this would need to be under the skin. Okay, so we have the tip or the dead space, and then the trough, the notch, the tissue acquisition chamber. All of that needs to be within the breast. So the breast thickness is really dependent upon the needle that you're using. You need to add up the dimension of the trough and the tip to know approximately the minimal breast thickness that you can use with that particular device. So here's a schematic of different types of needles. And this is what I just described to you as the standard needle, 8 mm dead space at the tip and a trough of 2 cm. So we think approximately 3 cm thickness to be able to proceed with a standard approach for that particular patient using that particular needle. Some manufacturers and facilities will have a petite needle. In this case, the tip is the same, 8 mm. The trough is only 12 mm, so that a breast that compresses closer to 2 cm still could undergo stereotactic core biopsy or tomosynthesis-guided core biopsy. Furthermore, there may be an option for a blunt tip petite needle where the tip is only 4 mm, the trough is again 12 mm, and so now we're down to 1.5 cm approximately. Manufacturers have now developed another approach to address the issue of a thin breast rather than changing the length of the trough or the dimension of the dead space or tip at the end. There's something called the lateral arm approach. In this case, the needle is advanced parallel to the plane of compression. So typically we are perpendicular, as I mentioned, and there is a hole, a window in this compression paddle, and the needle is approaching the breast in this direction. Again, kind of along the z-axis. Here, because the needle is parallel to the plane of compression, you can be successful in targeting this patient even if the breast thickness is minimal. You don't need a lot of space between the paddle and the detector in order to get the needle in there. It is easier to see the needle in the breast adjacent to the target. I'll show you an example, and this may decrease the accordion effect. I personally have found this a little bit of a challenge in a very thin breast only because I can't get my hand in there. I have to get close enough to the breast to clean off the skin and anesthetize. And sometimes I've just found it a challenge. I asked the technologist to try to place the edge of the breast as close as possible to the edge of the paddle, still with obtaining satisfactory compression. Here's an example of a lateral arm approach done at our institution, a screening mammogram in a patient with dense breasts, and there are very faint new calcifications here. As I mentioned, these are new. They were evaluated with diagnostic imaging. Here's an ML view. Here's the CC magnification view. These are very amorphous. Again, new calcifications that are amorphous need to be biopsied. So the patient was referred for mammographic-guided core biopsy. They are at 12 o'clock, very superficial, and the decision was made to use the lateral arm approach because her compression was less than 2 cm. So this is the scout image with the patient compressed in an ML plane. Here's the upper breast, the inferior breast, and our target calcifications. The needle was placed from above. Here's the pre-fire image, and you see the needle pointing to the target right here. And then post-fire image with a 2 cm throw, we see that the calcifications, the target, are adjacent to that trough. Notice how easy it is to see not just the needle trough, but the target. And this was a successful biopsy. You can see lots of calcifications in different cores here, 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 and this was DCIS. Other challenges besides a thin breast would be targets that are very close to the chest wall, patients who may not be able to climb steps to get onto the stereotactic core biopsy table, patients who cannot lie prone, and perhaps lack of physical space for a prone biopsy table. Here's what we have at our institution. We have a room that is dedicated to mammographic guided biopsies with a lovely mural there for patients to look at. And you see here with a patient lying prone, the back of her breast is actually at the level of the table. So if there is a target at the back of the breast, there's no way to get that within the imaging window. Well, one option is to bring the arm through the hole and rest the arm on a device that's attached to the table. And you can get a little bit deeper with this because the whole chest is going a little bit lower, so you can access a deeper target. An upright unit, though, is actually easier to obtain a deep target. I do not have this at my institution, but I know that you can get deeper targets because you don't have the thickness of the table in the way. Patients who cannot lie prone also are better addressed with an upright stereo unit. Also, these are add-on units, so they don't require a dedicated room and can be added on to one of your routine mammogram units. Here's an example of the patient sitting in a chair and the needle coming from above. And sometimes the patients are actually positioned in a decubitus fashion. So it's considered quote unquote an upright, but patients may be actually lying on their side. Again, you don't have the thickness of the table in the way. I'd like to go through one case to show from beginning to end how I approach these biopsies. So we're putting everything together right now. One of the most important thing is planning before the procedure is ever done. The first step is going to be at the time of the diagnostic evaluation when the radiologist should specifically mention which modality is recommended. When I'm scheduled to do procedures, and we may have 10 or 11 in a day, the day before or a couple of days before, I'm going to go through all of those cases. For each one, I review all of the images. I go back to the beginning. So even the screening mammogram, I'll start there. I'll look at all of the images, not just to determine whether or not I agree with the target that was recommended for biopsy, but are there additional findings that may require additional imaging or sampling? And this is important to know in advance. You don't want any surprises the day of the biopsy. And also, if there's additional imaging that needs to be done, you want to try to get that done before the day of the biopsy. By reviewing the images, you can determine whether or not you agree with the modality that was recommended for biopsy. We also determine what approach we want, whether it's superior, inferior, medial, or lateral, whether or not we're going to use tomosynthesis or stereotaxis. Do I need to change the needle that I'm going to use? Do I need a petite? Do I want to come with a lateral arm approach? And what do I think is the most likely diagnosis? This is somewhat time consuming, but very important to go through all of these steps prior to the day of the biopsy. The day of the biopsy, everything's already been figured out. You just need to communicate with your technologist. What's the approach, the technique, and which needle you would like? Also, go over the images with the technologist so they know exactly what the biopsy target is. As I mentioned, I review all the images from the beginning. So this patient was scheduled for a mammographic-guided core biopsy earlier this month. Going back to the screening images, I see a group of calcifications in the right upper outer quadrant at a posterior depth. She had also already had multiple prior biopsies in both breasts, MR-guided, ultrasound-guided. She was called back for diagnostic evaluation of those calcifications. I know they don't project very well here, but the circle is showing you that there is a small group of calcifications there. These are new. These need to be biopsied. Part of planning for a procedure is to determine which approach. In this particular patient, the calcifications are in the upper outer quadrant. This on the right is a CC magnification view, and on the left, an ML magnification view. So these are closest to the lateral skin. And we usually choose the shortest distance for the approach. However, there are times where we may modify the approach. One reason could be visibility of the target. Sometimes calcifications are better seen on one view than another, and even though they may be a long distance, you may want to come from a different direction. Also, I consider where the needle entry site and subsequent scar would be, and I try to avoid producing a scar on the medial or superior breast if I have a choice. Some patients do scar more significantly than others, such as patients who form keloids. So I'd rather bury the skin changes if I can. Another thing to consider for the approach is whether or not you would traverse large vessels going to your target from a particular direction. The choice of needles depends on your facility and the manufacturer. In my facility, we only have one gauge available. It's a 9 gauge. We do have different lengths of trough available with this manufacturer that we use, and we have 2 available, the regular and the trocar petite, not the blunt tip petite. Going back to the patient that I biopsied earlier this month, on the day of the procedure, I communicated with the technologist that I wanted a lateral approach. I was not going to use the lateral arm approach where the needle was parallel to the plane of compression, just a standard approach from lateral with a standard needle with a 2 centimeter trough. And I wanted to use tomosynthesis rather than stereotaxis. After all of the preparation and planning, I then go into the procedure room to consent the patient. In most cases, this is the first time I'm meeting the patient. In a minority of cases, I may have met that particular patient during the diagnostic evaluation. But I go over the procedure in detail. I show them the table. I go step by step what's going to happen. And then we talk about complications. The most common, although not common in and of itself, the bleeding and infection, those are the most likely problems if there are going to be any. And then I talk about clip placements. It's surprising how many patients hesitate regarding the clip because they don't like the idea of something metal in their body. Most of the time, after discussion of the importance of the clip, patients acquiesce to having the clip placed. If a patient refuses, it depends on the particular situation and the size of the target and whether or not there would likely be a residual target for localization for surgery if necessary. The patient then climbs up a few steps to get onto the biopsy table, not as high as this, but the table starts maybe about this height. The patient gets up on the table, lies prone, then the table is elevated so that we can work underneath. The breast is positioned between the paddles coming from a lateral approach here. This is her right breast coming from a lateral approach. And we start taking our images. The scout image shows that the calcifications come into focus at a Z of 25. And importantly, the technologist got it on the first try. So it was easy. We found the target 1, 2, 3. And then I placed my cursor right over the target and then make one check on my workstation, and the targets are transferred over to the screen adjacent to the needle, showing that these are our coordinates: X of positive 13.3, Y of 19.5, and Z of 25.0. We then clean the breast and proceed with local anesthetic. We use 1% buffered lidocaine for a skin wheel and lidocaine 1% with epinephrine for deeper anesthesia. I usually re-image following lidocaine because sometimes the target can move after the lidocaine bolus. So in this case, here's the pre-lidocaine image showing a Z of 25, and following lidocaine, there's a 2 millimeter difference. Not significant, but sometimes they can actually move a little bit more than 2 millimeters. And they can move not only in the Z plane, but the X and the Y as well. So we may need to retarget. Once the patient is anesthetized and we've repeated imaging, we go ahead and advance the needle to the satisfactory target of X, Y, and Z. Sometimes I make a skin nick if I feel that it's going to be challenging to advance the needle. For example, in a more anterior location near the nipple where there isn't good compression, it may be harder to get the needle into the breast. So I may make a skin nick to make that easier. Some cases I omit the pre and post fire imaging. With experience, I found that these are not always necessary and they do take time and they increase radiation dose. So I may skip the pre-fire and or the post-fire imaging if I feel comfortable that I'm in the right place. The target is large enough that I feel that if there's a slight movement with lidocaine, it's not going to make that much of a difference regarding success of the procedure. Then we go ahead and sample. Depending upon the size of the target and where the needle is relative to the target, I may go around in a circle or I may preferentially sample in one particular direction from the needle. Here are the samples again being collected in the chamber attached to the needle. We divide our specimens into the core biopsy tray. We can see on our specimen radiograph that we have representative calcifications here. The reason that we use this tray is our pathologists like to separate the cores with calcifications from those without. They do look at everything under the microscope. However, knowing which cores have the mammographically significant calcifications is helpful for them as they do their own rad path correlation. So we look at the specimen radiograph and say, okay, 12 o'clock, 9 o'clock, those are going to go into container number 1, and the rest in 3 and 6 and the center are going into container number 2. The needle is then withdrawn from the breast, and there's a sheath that remains at the target through which we can place the clip introducer and deploy the clip. Repeat imaging here confirms that the clip has been deployed. After the clip has been deployed and everything is removed from the breast, we hold pressure for about 5 minutes to obtain hemostasis. Some patients require a little bit longer, depending upon whether or not they've been on any blood thinners, but typically 5 minutes or so is enough. We put steri strips over the needle entry site and with a Band-Aid over the steri strips. When I'm holding pressure, I use that opportunity to go over the post-care instructions. So we talk about what to expect, how they should take care of the breast, what they should do if they have pain, etc. We give these instructions to the patient in writing, but it's helpful to go over them in advance. So if the patient has any questions, they can ask them right then and there. I then tell the technologist which views I want for the post-biopsy mammogram, whether I want 2D, do I want tomosynthesis, do I want modified views such as an XCCL. Sometimes we look at those images before the patient leaves the department, but sometimes we'll just tell the technologist, as long as you see a ribbon clip on both views, you can discharge the patient. We don't need to look at the images before she leaves. So the post-biopsy mammogram is important to know if the clip is at the target site and whether or not there are residual calcifications or residual target if it's non-calcified. So here, pre and post CC, pre and post ML, and the clip is at the target on both views and there are no residual calcifications. In a few days, the results are available and we call each and every patient with the results, what their diagnosis is, what's the significance of the diagnosis. Some of the terminology can be confusing. For example, lobular carcinoma in situ has the word carcinoma in it, but it really isn't a cancer. It's not treated as cancer, but it can be confusing. We go over the recommendations for follow-up, whether it's imaging follow-up in 6 months or can the patient go back to routine screening. Sometimes other biopsies are necessary. Sometimes patients need to see surgeons if the breast surgeon, even if the result is benign. And then patients who are diagnosed with cancer do need to see a breast surgeon. We provide the phone number to the breast clinic in the same building so patients can call and make appointments. We also reach out to the nurse navigators in surgical oncology to make them aware of all of the new diagnoses. It's always important to ask the patients how they're doing. How does their breast feel? Have they had any problems with bleeding or pain after the biopsy? And lastly, if it's a cancer diagnosis or something that needs surgical intervention, I will message or call the referring doc to let them know what's going on, even if we're giving the phone number for the surgical clinic to the patients. Radiology pathology correlation is an important part of doing breast procedures, and this should be performed by the radiologist who did the procedure. The diagnosis must make sense in terms of the imaging appearance. If the results are discordant, meaning they don't make sense with the imaging appearance, we may need to repeat a biopsy, maybe use a different modality for guidance, or potentially excise that part of the breast. If there are any questions, reach out to your pathologist. Go over what the diagnosis is. Do they think a radial scar in a biopsy for calcifications is related, or is it incidental? There are lots of incidental findings that don't necessarily need to be addressed. If the biopsy was for calcifications, it's important to note whether or not calcifications were in the specimen radiograph for evaluation of concordance. There are some times where we target calcifications and we may take a second sample after retargeting, but we still don't get the calcifications. It's hard to say a benign pathology result is concordant if you haven't gotten the calcifications. On the flip side, if you haven't gotten the calcifications, but your diagnosis is cancer, then you don't need to repeat the biopsy. There are cases of non-calcified DCIS. We know that the extent of disease is larger than the mammographic representation. So in a positive case, it may be acceptable not to have seen the calcifications in the specimen radiograph. The pathologist should comment on the presence or absence of calcifications if calcification was the target of the biopsy. If the specimen contains both benign and malignant processes, I want the pathologist to tell me which process is associated with the target calcifications. For example, if the specimen has both fibrocystic change and DCIS, and the biopsy was for calcifications, if the calcifications are associated with the fibrocystic change, even if there are residual calcifications, they may not all need to be excised because that's a benign process. For non-calcified targets, your pretest probability of cancer is really important because we don't have the specimen radiograph to establish satisfactory sampling. The clip location on the post-biopsy mammogram will help you determine whether or not you biopsied the right location in the breast. And for these targets, I find that tomosynthesis on the post-biopsy imaging can be very helpful for evaluating the presence or absence of really a minute residual lesion or calcifications. In these patients with non-calcified targets, a post-biopsy hematoma may obscure your underlying target. And so if the diagnosis is benign breast tissue and you targeted a mass, it may be useful to have the patient come back in a couple of weeks to make sure the clip is in the right location after the post-biopsy changes resolve. And some findings, even if the pathology is discordant, may still require excision. For example, a large area of architectural distortion, if radial scar is found on the pathology, if it's a large area, they still may need excision. So post-biopsy mammogram is important to show whether or not the clip is in the right spot. So in summary, I've hoped that I've shown you that percutaneous biopsies play an important role in patient management, whether or not the targets are benign or malignant. The most common target for a mammographic-guided biopsy is a group of calcifications. although other targets are appropriate, such as masses, distortions, and asymmetries. Targeting can be performed either with stereotactic imaging or tomosynthesis, the latter being most commonly used at our institution, but both work very well. Most patients tolerate these biopsies with few complications and with challenging targets. With a few modifications, we are usually successful in biopsying the area. And finally, RAD-path correlation is important with any percutaneous biopsy, and this is the responsibility, or should be the responsibility, of the radiologist performing the procedure. Thank you.